Good morning, respected chairs, senior faculties, my colleagues. So, at the outset, let me thank Dr. Manikandan and Dr. Kiran for giving me this opportunity. So, today's topic, my topic is evaluation of reversible cardiomyopathy. We all heard that cardiomyocytes are non regenerative. So, how is it reversible? Cardiomyopathy is a condition that affects the heart muscle with systolic dysfunction and cardiac dilatation. But many of the studies found that there is 20 to 50%. I know it's a big range, probably in the reviews because of the selection of different population. It is found that 20 to 50% of them are reversible. How is it possible? The mechanism for the myocardial damage maybe can be inflammatory. At times, it may be due to perfusion defects, as in ischemia, and sometimes some RNA reactions. All these can be decreased if you picked up them early and treat it. So, decreased inflammation can decrease the fiber tension, and even it can shorten the dilated fibers that make the myocardium to recover, and almost normal function is achieved in majority of the cases if it is treated appropriately. And few of them, despite all the our efforts, it may go to dilated cardiomyopathy. So, as Chairperson Udebanu sir has already enumerated, these are the basic etiologies of acute dilated cardiomyopathy, mainly the inflammatory or infectious, where the inflammation is the key role for the cardiac muscle damage. It may be viral. Viral it may be directly cardiotoxic or cardiotoxic viruses, or it may be immune mediated damage by the virus. Then generalized autoimmune diseases can affect the heart. Sarcoidosis is another inflammatory disease, and in many of the ICUs, we used to see patients with septicemia. They get troponin elevation, hypotension, and cardiac dilatation. They are basically septic shock induced inflammatory cardiomyopathy. Then the second variety is basically the sympathetic excitation by the catecholamine mediated. The well known is the Takotsubo or the broken heart syndrome, which is secondary to high intense emotional stress. Then pheochromocytoma, as we know, it secretes excess catecholamines that can lead to myocardial damage. Then toxins and drugs. Alcohol cardiomyopathy is well known, especially with arrhythmia as a presentation. Then cocaine, methamphetamine usage, and many of the cancer chemotherapeutic drugs, at least few of them can have permanent damage, few of them are reversible, and immune checkpoint inhibitors can lead to myocarditis. Then sometimes we know the heart rate should be in the range of 50 to 70 in a normal person, but if the heart rate is faster for prolonged time, as in sustained tachycardias, it can induce cardiomyopathy. And in some patients, premature ventricular contractions, because of its rhythm changes, it can also lead to cardiomyopathy. Then metabolic causes and hypoventilation, uremia, cirrhosis, thyroid disorders, all these can lead to cardiomyopathy. Sleep apnea is another cause of reversible cardiomyopathy. And well-known entity in the peripartum stage in the last month of pregnancy to 5 months. These are in short the major reversible cardiomyopathies. Along with that, if ischemic cardiomyopathy is there, when the ischemia is reverted, the muscle function usually improves if there is no fibrosis has already set in. So these are the speculated mechanisms. Inflammatory and infectious disease, basically autoimmune mediated, and then tachyarrhythmia induced. It is basically the adenosine triphosphate depletion. So it has got a very good reversibility once the tachyarrhythmia is fixed. Then sympathoexcitation is also due to calcium homeostasis change. It also has got a very good reversibility. Then in metabolic, as we all know, hyperthyroidism and hypothyroidism by adequate treatment, the cardiomyopathy can be reversed. In chronic diseases, cirrhosis can lead to cardiomyopathy, Also along with that cirrhosis, patients can have pulmonary AV fistula. So many times patients may present with unexplained dyspnea. LV function may be normal, but saturation will be low. So doing a saline contrast test sometimes pick up the pulmonary AV fistulas. These patients are actually candidate for liver transplantation, by which cardiac conditions will be reversed. Then obesity, and in uremia we see cardiomyopathy with LV hypertrophy, unlike in other metabolic diseases. So what are the clinical clues? In viral myocarditis, usually the cardiac failure symptoms will have an antecedent flu-like symptoms in about 75 to 80% of patients. Peripartum cardiomyopathy in the last month of pregnancy or up to 5 months postpartum. Stress-induced cardiomyopathy usually will have a history. Catecholamines and pheochromocytoma, a patients presenting with recent heart failure with previous multiple episodes of paroxysmal symptoms of palpitation, headache and diaphoresis. And hyperthyroidism usually will have the external features of thyroid excess, and in adrenal insufficiency, symptoms of fatigue, weight loss, and darkening of the skin creases, and orthostatic hypotension. Tachycardia-induced cardiomyopathy, the patients can have tachycardia due to cardiomyopathy itself, but tachycardia-induced cardiomyopathy usually will have a reentrant arrhythmia or slow VTs, and in some patients with premature ventricular complexes. And deficiencies like thiamine deficiency, you can have a reversible cardiomyopathy. A patients with inflammatory bowel disease or any nutritional deficiency suspected, you can think of thiamine mediated reversible cardiomyopathy. And drugs and toxins from the history, and cardiac sarcoidosis. Many patients with extra cardiac sarcoidosis is already there, and if there is unexplained LV dysfunction, think of cardiac sarcoidosis. And cardiac sarcoidosis can present even without extra cardiac involvement, and the clinical clue at times is basically the advanced heart block or arrhythmia at the time of presentation with LV dysfunction. So these are some clinical clues. And as we all know, echocardiogram is the first imaging modality for the LV dysfunction evaluation. Segmental valve motion abnormalities with coronary artery distribution is suggestive of ischemic cardiomyopathy. In myocarditis, especially in the acute or subacute stage, the LV dilatation will not be much there, but there will be profound decrease in ejection fraction, and along with LV thrombi. So that picture is more suggestive of myocarditis. And in acute fulminant myocarditis, which is more catastrophic presentation with hypotension, usually the LV myocardium will be thick because of the inflammatory infiltration. And in sarcoidosis, about for majority of the sarcoidosis in the acute phase, you will not have scars or thinning. It will present as unexplained LV dysfunction. But if it is an advanced stage, basal septal thinning and focal aneurysms are echo features. And Takotsubo cardiomyopathy, you have the characteristic apical ballooning with hypercontractile base, even though there are some reverse patterns and isolated patterns of Takotsubo cardiomyopathy do exist. The lab investigations, usually the creatine kinase to look for any associated other myopathies, renal function to rule out renal disorder as a reason for LV dysfunction, proteinuria, liver function test to rule out the metabolic causes, hemogram, sometimes polycythemia, and all these things can lead to problems. Serum iron, ferritin, and calcium hypocalcemia sometimes can present with LV dysfunction. There has been case reports, and thyroid evaluation. The second line of evaluation is basically the autoantibodies and a profile. And if you are suspecting myocarditis, the non-Coxsackie echo influenza viruses can be tested if it is available. And HIV and hepatitis B and C, they are actually, HIV and HCV are basically, they are directly cardiotoxic. So anti-viral therapy is found to be very efficient, very useful in making it reversible. So early diagnosis of that and treatment of that will lead to reversal of the dilated cardiomyopathy. And Chagas disease, if the patient has got geographic exposure, and thiamine levels, if the patient has got any, is a chronic alcoholic or any nutritional deficiency, and if there is an inflammatory bowel disease. And if you are suspecting pheochromocytoma, send urinary VMA and metanephrines. Serum is if you are suspecting sarcoidosis. And myocarditis is the major chunk of this. We know inflammatory cardiac disorder, it is predominantly induced by viruses. Various viruses from influenza in 1950 to the COVID virus in the 2020 has been implicated. And bacteria, protozoans, and even newer chemotherapeutic drugs, immune checkpoint inhibitors are also associated with myocarditis. Among these viruses, as I have already said, the cardiotoxic hepatitis C virus and HIV virus, they have got good response to the antiviral therapy. In all others, it is still doubtful. Now, the diagnosis of myocarditis has been with endomyocardial biopsy, but in 2018, the Lake-Lewis criteria has made MRI as diagnostic for myocarditis, because in this imaging modality, you can detect both edema and myocardial injury along with the other signs. So MRI is now a class 1 recommendation according to the European guidelines for diagnosis of myocarditis. To make things short, we have T1 weighted images and T2 weighted images. T1 is basically for fat, enhancing the fat, and T2 is basically for enhancing the water. So T2 based images will detect the edema, and T1 based images will detect the injury. So the T1 weighted, when we have combination of both T1 and T2 images, we can detect edema with the inflammatory necrosis, that is diagnostic of myocarditis. And in another T1 weighted, that is the late gadolinium enhancement, you can also see fibrosis, and if it is, there is associated T2 weighted edema is also there, you can consider it as a inflammation. So there are different patterns for different non-ischemic cardiomyopathies. Basically the mid-wall LGs are more suggestive of non-ischemic cardiomyopathies, and in sarcoidosis you can get even epicardial and mid-myocardial. Now regarding the chemotherapeutic drugs, anthracyclines are the most common attributed cardiomyopathy inducing agents. So actually we have to do a pre-therapy evaluation and a serial monitoring by echocardiogram to prevent further toxicity with anthracyclines. Alkylating agents are basically for the pre-therapy, and trastuzumab, which you have both, we have to screen it with, and pre-therapy also has to be done. Now PVCs, whether it is a culprit or a bystander, usually PVCs can lead to cardiomyopathy. PVCs, if it is due to, if it is the etiology, usually ejection fraction will be much more better, and the PVC frequency will be more than 10,000. Now regarding one word about cardiac sarcoidosis. In cardiac sarcoidosis, it is basically, the imaging modality will be combination of FDG PET with cardiac MRI, because FDG PET you can detect both perfusion and metabolism. You can see the upper part of the slide where perfusion is normal and there is no FDG metabolism. That means a normal myocardium. As the lower picture shows that wherever there is a perfusion defect, there is a metabolism uptake. So there is a perfusion metabolism mismatch, which is suggestive of highly active sarcoidosis. The importance is that sarcoidosis is very responsive to steroid therapy. Even with 2 months, it is reversible. So to conclude, 1/3 cases of dilated cardiomyopathy are reversible. Early diagnosis and treatment can lead to excellent outcomes. Cardiac MRI and FDG PET imaging are cornerstones for early detection now. Thank you.
For this, I have one question. In these reversible cardiomyopathies, how long should we continue the heart failure drugs once the LV has completely recovered?
Usually they will have systolic dysfunction. even it will improve to mid-range EF or even into the normal EF. The guidelines are not, I think it is not very specific, but it is better to continue with the neurohormonal antagonists to continue at least to few years. Maybe I am not aware of a guidelines when to stop it actually.
I think we should never stop. Possibly. I mean, what will be your advice to the physicians on we are increasingly seeing the instances of tachycardiomyopathy, and I'm sure there are many physicians who treat atrial tachyarrhythmia. What will be your advice to them?
One of the commonest is that when there is whether it is PVCs, premature ventricular contractions, and this LV dysfunction. If the PVCs has got multiple morphology, and if it is LV dysfunction is more severe, the PVCs will be more of a effect of cardiomyopathy rather than PVC is the cause. If PVC is a cause for cardiomyopathy, usually the ejection fraction will be much more better in the tune of around 35 to 40, and the PVCs will be monomorphic. So if it is like that, then maybe doing a Holter and to assess the PVC burden of more than 10%. Many electrophysiologists take more than 25%, I think. So then only they do take them for ablation. Other reentrant tachyarrhythmias and other slow VTs, they are and atrial flutter mediated cardiomyopathy are excellent substrate for ablation and to get the cardiomyopathy reversed. And atrial fibrillation is now also is a new area. If it is induced by single PVCs from the pulmonary vein, they are also amenable for ablation.
Thank you, sir.